Well, I'll talk about the lessons learned from those collaboratives. But before, I don't know how familiar everyone is with collaboratives. So I'll go through some steps in a brief way. Then what happened in Portugal and Brazil, the results, and finally the lessons. So I have no conflict of interest to declare in this presentation. So as Theo said, the collaborative projects, they have a driving vision behind it, that if we apply all the knowledge we have, all the scientific evidence we have, the costs and the outcomes will be greatly improved. However, much of the scientific knowledge is not used in the daily work. So the idea behind a collaborative project is to decrease the gap between what we know and what we do. So there is no objective or intention or aim to create new knowledge, but to apply the knowledge that we already have. So the framework is basically two phases in the collaborative. The first phase would be a preliminary work where we decide what we're going to do, what the objectives are, the aims, the measurement strategy. Building that, we just present that for a group of experts to see if any adjustment has to be done, anything we left out, anything we have to add. And finally, then we start doing the collaborative itself. That is an alternate structure between learning sessions and then action periods, where, as the name says, they will do the work. They will do the change tests, they will do monthly reports, happen coaching calls, and the project goes with many tests. And then comes another learning session, can be virtual or can be in person. After COVID, of course, they have been virtual, but as soon as possible, we're going to return to some in-person or face-to-face meetings because the energy and the interaction is much better. But no question, the virtual option will be always there. What we use to work and try to change anything is the model for improvement. The model for improvement has three questions. They are kind of intuitive, but it's a robust model, and not always we can answer those three questions easily. The first one, it's what we are trying to accomplish. The object basically should be very specific to a problem, and always centered in the final user. The second question, it's about measurement, how we going to do what we call the quality measurement journey. We start with the objective of that collaborative until we get the operational definition, data collection, report, analysis, and action. And the objective here, again, is just how to act. We're not collecting any kind of data for any judgment or to report to anyone else besides the group of the collaborative. We have usually a package of changes or a group of changes that we propose to reach that aim. This is just an example. Many of them will be applicable for most of the participant units. Some of them will not. So eventually we have to consider the context of every participant, and they will test the changes they think are applicable or make sense for them. This way, the 5 elements of a collaborative is to have a very clear aim. Again, has to be a specific and final user focused. You need a theory of change or change package of a group of ideas, at least where do we start from. A measurement strategy, so the indicators will be key to know if we're going to reach the aim, if we're in the right path or not. And we need a theory of execution, a method. As I just said, it's the model for improvement. And the fifth element, the dissemination, actually happens only after we reach the goals of that collaborative. We have learned how to do it, and then makes sense to spread and to involve other units or other participants, other teams, and so forth. Another way to look at those collaborative elements is this figure here, where you have the center, the aim, and then you have the change package. And this is really important, because the change package, we of course look at the scientific evidence, the bundles of care, for example. And usually, especially doctors, the first thing they look is at this kind of pillar, the pillar, the scientific evidence. But it's not only that. We need leadership engagement, we need teamwork, and usually we do involvement of patients and families. So those four pillars actually will make a strong change package. So if we just focus on the scientific evidence, what's essential, critical, it's not enough most of the time. Involving all that is the measurement strategy, and then the model for improvement. And the only component that is not there is the dissemination. What happened in Portugal and Brazil was very similar in both countries, because the method is the same. So I will take a little bit more time in the Brazil because it's a larger, much larger collaborative. But usually what we have, the voluntary participation. So the teams, the hospitals, they need to, they are free to choose to participate or not. And this is crucial, because if they are not in their moment, they don't have, they are not interested, they have no urgency to do that, and so forth, they will not work properly. They will not dedicate themselves to reach the aims. So voluntary participation was very important. In Portugal, was 19 hospitals involving 30 ICUs. The duration of 3 years starts in 2015, went until 2018. And during this period, more than 4,000 professionals were trained or involved in the model for improvement and the indicators and so forth. One thing that is very nice and characteristic of those collaborative is a very good interaction with the teams, with the front line, with the managers from that hospital, that ICU, that organization. So it's a very close contact, participation, to understand their contacts, to help them to overcome barriers and so forth. And we're going to see this in Brazil as well. In Brazil, we had a larger collaborative, again, voluntary participation. We chose hospitals with at least 100 beds, ICUs with at least 10 beds. And they should have an active hospital infection control committee working, active and participating in everything. And we selected 120 ICUs to start this collaborative. We are now in the second phase with new 200 ICUs to continue the same process. The aim for this collaborative was the same as Portugal, was a 30% reduction in CLABSI, central line associated bloodstream infection, CAUT, catheter-associated urinary tract infection, and VAP, ventilator-associated pneumonia. Again, in 18 months would be 30%, and 36 months or 3 years, a 50% reduction. Since the structure here was much complex, we have 5 hospitals, private hospitals, that they're very good facilities, very organized, that would function as hubs to facilitate what's going to happen to the public hospitals. That was the goal of this collaborative. So each one of those hospitals that we'll call hubs, they will take care, they will give support to 24 public hospitals. They will make the total number of ICUs participate. What happened in our main challenge in Brazil, it's just geographic. We had ICUs all over the country. As I said, all of them were public hospitals. In Brazil, we have two systems, the public and the private health system. And at that time, we didn't have COVID, so we tried at least most of the time to be presential, to be in person, to be face-to-face. And just to have an idea, if you go to the Porto Alegre, was a very south city for Brazil, until Boa Vista, another city in north of Brazil, it's a almost 9-hour flight to travel from one point to the other. How was the execution? So the execution was just, as I said, to get close to those participants and to have periods of learning sessions. In this case, just an example of an in-person learning session, and then work through the action periods with coaching calls and regional meetings as well. The first presential session happened in 2017, was focused on the model for improvement, tasks for changes, the PDSAs. And you can see we had a huge group, almost 700 people participate in this in-person learning sessions. In these learning sessions, many things happen, including clinical workshops. We're going to see that's one thing that we learned. We thought they knew exactly how to do everything, but they were not doing because, well, the conditions, the system, but actually they had a lot of doubts. When you say, well, we have to do oral hygiene for prevention of a VAP, they have many doubts. We have to insert urinary catheter with aseptic technique. And again, they have doubts. Of course, they knew how to do it, but was it the best way? Was it the proper way to do it? So we used these clinical workshops with simulations, mannequins, and everything to retrain and to show them again what they were supposed to do. And it was really interesting because most of the participants, again, were frontline workers. They will deliver the care. They will improve the rate of infections. So they have to be there. We have to listen to them and see their doubts. And again, here, another example of an in-person session. We have invited different speakers. You can see here, Don Berwick was a founder of the IHI, Paulo Souza from Portugal, because he had an experience in Portugal and could share with other people. So it was like small, let's say, congresses, small symposiums to talk about the collaborative, the model for improvement, and so forth. One thing very important in those sessions is the storyboard session. So every team would come and present to the other ones what they were doing, in what aspects they succeeded, what's the barrier they found, how they overcame those barriers. So it was an exchange of knowledge and experience among ICUs that were pretty much the same thing, working in the same system, the public system. So it was really interesting the impact of those storyboard sessions had over everybody there. Because if someone comes from a private hospital or from the US or from any other developed country and come there and say, look, you have to work this way, and this way. Okay, everybody will pay attention, but it's still an outsider telling them how to work. And here was a change, was a switch. They did the tasks. they succeeded, and they now can teach the others how to do the same thing. The visual management was a requirement in all of those participants. It's nothing new, but usually they didn't have that. So we want like a big board where they could put all the results, the graphs, the tests they were doing, in what part, what aims they have reached already, or what aims they are struggling to reach. And this was very interesting because keeps the project alive every day in that ICU. And we had daily project huddles. So huddles, very short meetings, 10, 15 minutes in front of the board. They could show some results or talk about something that happened, something they succeeded, something they are not, they're struggling. So was really made a big difference. Another thing was the site visits. Again, that time we didn't have COVID, so it was possible to go to every single hospital, talk to them, understand their context, see what the problems they face, and was really, really productive. When COVID started, we continued to do site visits, but then virtually. What happened is we already knew all the teams, the hospitals. So the virtual visits, they worked perfectly as well, but I'm not sure the impact of virtual visits only. But currently, that's what we are doing. We don't have any other option besides being virtual. We hope we can change that and come back to in-person visits. What results we got? So this is from Portugal. In terms of CLAPSI, we reached a 56% reduction from 2.8 to 1.1. So you can see at the beginning is they were higher. Portugal, in terms of CLAPSI, was not that high compared to some places in Brazil. But again, 56% reduction of loss. In terms of county, 66% reduction from 9.6 to 3.15. In terms of VAP, 56% reduction, starting around 9 until 4.60. After the collaborative ended, of course, the project itself ended, but they continue to collect data, and they currently are in better rates than before. What was very nice was they could sustain the results. It's a very big concern if after the project ends, if they will continue to improve or if they can maintain those results or not. But so far, most of the hospital know it, of course, not everyone, are doing the same. So at that time, we estimated that we have prevented 1,710 infections in Portugal during the collaborative. In Brazil, we had similar results. In terms of CLAPSI, was the least reduction we could get, was a reduction of 48%. One interesting thing is that usually we measure the number of catheter days between infections or number of device days between infections. And at the beginning, none of those ICUs had more than 1,000 catheter days between infections. And at the end, the collaborative, 42% of those ICUs already have had more than 1,000 catheter days. In terms of CAUTI, urinary tract infection, the reduction was 68%. And again, we started with 0 ICUs with more than 1,000 catheter days between infections, and that at the end of the collaborative, 63% of them were already with more than 1,000 catheter days. So it's another way to see how much they are in. That was the same thing, a 52% reduction. We was the most difficult one for us to get more than 1,000 ventilator days. But even though we start from zero and we could reach almost 15% of the ICUs with more than 1,000 ventilator days between infections. Another thing that I forgot to mention, it's the engagement of them. On this table, on the right side, you can see that almost every single ICU from the 120 were reporting all the data required. We had 51 indicators from each bundle for, the involvement and leadership and everything. And as you can see, the rate of monthly report in terms of our indicators was from 89, 90 to 99%. What helped a lot for the conclusions and to work where we had problems. This is just an estimate, but we can see here in Brazil that the total infections avoided was 7,674 infections. And if you consider what is in literature in terms of the impact in mortality from each one of those infections, we estimated that we could save, it's just an estimate, we saved 2,000, more than almost 3,000 lives. Another thing was did in Brazil, we tried to calculate the costs of every infection in those hospitals. We didn't work with the whole 120 hospitals. We got 20 hospitals that could follow the costs. And actually, we think we saved more than $64 million in these 3 years. The cost of the collaborative, because we have to travel to go up and forth and bring and have meetings, was $7.5 million during the 3 years, but the savings were almost 9 times that amount. If we compare here the results from Portugal and Brazil, as I said, the goals were the same, the structure, the method were the same. So we can see that in couch was a very high reduction, 68%, 66%. Eclepsy in Brazil a little bit less, but even though very close to Portugal, 46 and 56% reduction, and that 51 and 56%. Was very interesting because during this period in Portugal and in Brazil, we didn't hire more people. We have not asked to the hospitals to hire more people. We didn't buy any special equipment, material, anything. They had it all already because it was very basic. So it's hand hygiene, was the right dressing, was oral hygiene, was remove sedation or sedate less your patients under mechanical ventilations, and all those things that that are part from the bundle of care to prevent hospital-acquired infections. What were the lessons learned? If I could start from the big picture, I would say that make the front line part of the co-designing and the testing, the implementation of changes was key, no question at all. Again, it's kind of obvious, but they are the ones who will deliver the care. They are the ones who will decrease infections. So they have to be part of everything, not only during the execution, but designing, implementing, testing, and everything. Another key thing was leadership, no question. Leadership is not enough to go there and say, look, your project is very good. Oh, do that, it's important. It's more than that. They should do rounds. Well, very short. We know they have many other things to do, but they have to be there, present in the front line, participating in an active way from the project, following the results. Another thing really important, bring joy to the work, to the improvement initiatives. Every time we started in a hospital, the first reaction was, well, more work. Now they want us to do this, that. We are already overwhelmed, and this project, they want this, they want that. But after they start realizing, they will learn things. What they will learn will be applicable to their even personal lives, professional lives, for other things. And of course, they will benefit the patients, the families, and everything. We changed the way they look. I remember when they said, unfortunately, we have to collect a lot of data because if you don't do so, we will not know if you are in the right path or not. Was the same reaction. We collect so many things. We do already so many things. And you guys want this and this and this. And we start slowly, we start showing, and they start getting the results. And then they start getting more and more involved. So at the end, they actually were happy and proud of the accomplishment. So bring joy to the work is essential. What else? As I said, co-design strategy changes according to each particular context. Even all the ICUs were public in Portugal and in Brazil. They are different, depending where they are, depending on what kind of hospital or what kind of population they see. Site visits had high impact in the engagement team. And we tried to make the improvement teams protagonists of the collaborative. So at the end, not at the beginning, but from the middle one, they were present reviews. They were presented their work. They were participating in roundtables with us. Everything was inside the collaborative. And this made them really proud and committed to continue the work after the collaborative ended. Storyboard sessions had the same function. Again, they were really, really interested in showing what they are doing, what is working and what is not. And then was a big change of experience between the hospitals, not someone who has come from the US to teach them how to do, but someone who is their neighbor, telling, look, if you do this way, you're going to have much better results. We tried this, didn't work. Why don't you try that? So it was a community of learning for sure. And finally, the clinical workshops with the small group discussions, simulation of the bundles of care. They all knew the bundles of care. The point that the way they executed them were not really the best way to do. So it was really nice. For Brazil, we had 120 hospitals. So a decentralized design with hubs to follow up and support those hospitals really worked well. Now we have the same thing with 200 new ICUs. We have just started a couple of months ago. The virtual learning sessions, they work very good when the teams already knew each other. Sometimes during COVID, we didn't have any other option but to do everything virtual. But most of the time, if we had a group of people that know each other, they will work better. And finally, standardization of many bundle components was interesting. In the same hospital, in the same ICU, you could ask, how do you do, medication in the catheter? What the steps? Or how you change this dressing? And you could see that different people do it differently. So we start to standardize, trying, considering the context, but to have everybody working in the same manner. Challenge or disbelief at the beginning, as I said, lack of leadership engagement. the hospitals who had let's say, not very good results were where the leadership didn't engage at all. High staff turnover was a kind of struggle to empower the frontline team, particularly nurses. So was very doctor-centered, medical-centered, but actually, again, who delivered the care has to be empowered to make decisions. Not giving the improvement team some protected time to work on the project. Sometimes they believe you have to do your work, and in your free time, you can look at the project. Of course, they have to continue doing their work, but a couple of hours a week of protected time will make a very big difference. And physician engagement, as you know, the whole world is always a little bit more difficult to reach. But we select the physicians who were already engaged and try to make them the champions to bring more physicians to the project. This is essential, especially in the ICU. We need the intensivists to be part of everything. But usually the first reaction, I have a lot of things to do. This is a nurse problem. Until you change the mindset, this is our problem. Every infection in every patient is our problem. So those are the main challenges we face. That's what I had to present.